Well, thank you very much, Daphna and team. I thought we would talk a little bit today about directions we should be thinking about for the future of NICU follow-up. And I do just want to say, first off, this is going to be a high-level discussion. In no way am I going to be able to touch on all of the great, amazing ideas there are for this topic. But I also want to say there have been some truly spectacular talks at this conference over the last few days that directly touch on or really directly connect on this topic. So hopefully we will all, in the final moments, be able to integrate all this information together as you're hopefully headed back home. So what do we think about NICU follow-up? What do we generally think about when we think about this? Well, we generally think about a limited timeline, only ending at 2 to 3 years, and that is not long-term follow-up, by the way. And there is generally a focus on medical and neurodevelopmental endpoints. So that means neurologic exam, generally around 2 years for cerebral palsy, some developmental tests that results in a score, and neurosensory outcomes. And to some extent, this is due to the fact that a composite of these components, neurodevelopmental impairment, NDI, or NDD, is very frequently the primary outcome or a main secondary outcome that's chosen for neonatal clinical trials. So this is not to say that neurodevelopmental outcomes are not important. They are important, but they are not everything. They're not everything to parents and families, and they certainly do not encompass the direction that we need to go, which is for wraparound engagement and care for families all the way through the continuum. So we also know that the NICU experience and teams and the high-risk infant follow-up experience and teams are often very siloed and separate. So in fact, the communication may be limited to just the process of referral to follow-up. So although each of these groups have connections to the child and parent, very frequently, they are not joining together in joint goals to support families, which I would propose includes parent mental health support projects and could be the topic of an entire Delphi conference, which I would really love to attend. Also, these strong connections, if we don't have them, we're missing a lot of opportunities for things like bringing families into this continuum of care and hearing their voices, networking with other NICUs and high-risk infant follow-up programs, and building frameworks for quality improvement, research, and advocating together and connecting to the community. So where we really need to get to is an integrated continuum of care, starting from ideally before the baby is even born and going all the way through that entire journey with children and families. So how do we get there? So I would propose that we have to fundamentally shift our view of what is referred to as NICU follow-up. And there are a few frameworks that we can look to help us think about this shift. And I'm just going to touch on two. And one, I think, is very familiar to probably everybody in the audience, and that is described by the seminal paper by Jeff Horbar and colleagues that asks us to not think about follow-up, but to reconceptualize as follow-through. And this construct really shifts from the medical and neurodevelopmental focus that we think of now, and instead stresses the responsibility that we all have, no matter where we are in the care continuum, to identify and address social risks and systemic inequities and all the other barriers that families face across the continuum. So as you probably know, there are 71 potentially better practices that are identified in this paper. And they are organized into these 6 categories that you see here. And that may seem overwhelming, but remember, the point is not deploy 71 potentially better practices, but to look together with your team and ask, where are the gaps? What can we do today to make things better? Another approach that might be considered related is to look at follow-up through the lens of life course. And so the construct of life course health development takes a longer view, and it is a very inclusive and integrated view that integrates families and supports and communities. This is a framework that stresses flexibility, and it also stresses individual patients and individual environments. So this is getting away from the kind of cookie cutter, rigid approach that we may think of as follow-up today. And all of this really means understanding with the family, what does thriving mean for that child? What are your goals for that child? And then that means harmonizing individually the services and the supports that a child needs to get there. So this, again, may seem overwhelming. And you may say, well, you know, what you're really talking about is a complete remodel of the healthcare system. And I will say, yes, I do think we need to get there. But for today, I think we can learn from the components of these frameworks and say, how can we make our system better? What can we bring in to our program now to try to start moving that trajectory? And one, I think, of the most important things that we can do is to listen to parent voices and to integrate perspectives that are important to them. And I will say one of the world-renowned investigators in this area we all know is Annie Janvier. And she is shown here, and she is here at this conference, gave a fantastic talk yesterday. And this work has really helped us to learn that there is a fundamental disconnect from a lot of what parents think are important to what we as investigators are focusing on in terms of our outcomes. This work has also shown us, and this is a figure from one of the papers that Annie's group has done, that development is identified as important to families, and that's the biggest bubble there. But what that means to families may be quite different from what we think it means. So they identify in that emotional health, building relationships, communication, all things that we may not focus on in our research. Abby Eales and co-investigators in Australia and New Zealand, including seen here Alicia Spittle and Jeannie Chung, asked parents about their research priorities and all along the continuum, so not just in the NICU, not just early follow-up, but all the way to adolescent. And although they identified many child-focused outcomes and research questions, they also identified an enormous number of parent and systems-related research outcomes. And that includes how can parents maintain mental health and emotional well-being through this process? How can institutions help us to bond with our babies? How do we build partnerships with healthcare systems? All things that are incredibly important, but we do not spend a lot of time focusing on in our research. And so I would say the take-home here is that listening to parent perspectives and their ideas really should and can be integrated into our decision-making about what is the next trial we should focus on, and bring in their research questions into that discussion, and bring them into that discussion. So this brings me to another point that I think is a good one for us to think about in the future of NICU follow-up, and that is the power of making connections. So those connections, of course, include what we just talked about, connections with parents and families, and harkens back to the importance of connections between NICUs and follow-up clinics and teams, but it also means that that powerful connection can facilitate other connections with the hospital, with advocating and connecting with the community and so forth. And this, in turn, can build some very powerful networks that can get some stuff done. And one example of this network of this kind of network is the California Perinatal Quality Care Collaborative, or CPQCC. You heard about this yesterday from Henry Lee, and I think a lot of people think about the CPQCC from the NICU perspective. But the CPQCC also partners with the Department of Healthcare Services in the state of California to lead and support all of statewide high-risk infant follow-up for the state. And so that means that as a network with stakeholders involved, we can say, yes, we are going to collect this important information far beyond neurodevelopmental outcomes and share it locally and regionally. And in fact, there are site-specific, real-time, site-facing reports for follow-up clinics that include things like parent concerns, service access issues, other kinds of barriers that are due to social determinants of health. But in addition to that, NICUs have the same view. So they can see the longer-term outcomes for the children that are coming through their NICU as well. And this has really created conversations between NICUs and clinics, and it allows for parents and families to hear the same information. And importantly, it allows teams to identify where are there problems, what can we do in terms of quality improvement here. This network also allows us to help sites, both with operational dashboards, but also with health equity dashboards. So again, you heard about NICU-based health equity dashboards yesterday. We also have site-specific health equity dashboards for follow-up clinics. So what that means is sites can look at this information and they can see the disparities that exist in their clinic. They can see that there are follow-up rates that differ between race and ethnicity, or primary language, or insurance, and they can look at other disparities as well. And this has been a powerful tool that has really helped NICU follow-up sites to say, we've got a problem, we can't deny it, and we really need to do something locally. Another great example of this kind of networking is the New England Follow-Up Network that is led by Jonathan Litt, shown here. And this is a multi-state collaboration of follow-up clinics. And what this group has done is shown not only feasibility of bringing together multiple states in follow-up networks, but also, again, has uncovered variation in clinic practices, in service access issues, and other issues that are targets for quality and process improvement for this network. In addition, everybody probably knows about the Vermont-Oxford ELBW follow-up network. This is a growing concern. I think there are more than 60 sites that participate now. And not only do they have site-specific reports for the data that they collect, but they now are offering the opportunity to get together with other sites and have regional networks and be able to get reports for those networks all together. So I think that if you don't have a network that you're working with right now, this could be a good opportunity. So in the final few minutes that we have today, I just want to talk a little bit about the importance of shifting from a kind of observational mode to more of an interventional stance. So there are literally thousands and thousands of publications now that talk about risks, that talk about adverse outcomes. And there are some, fortunately, growing number that talk about family goals. So I think now, I'm not saying any of those are not important, they're important, but I think we do need to shift toward having more of a research and quality interventional stance, that we can deploy evidence-based interventions, and that we can also do some focused research on what interventions will work for some of these outcomes that have been identified and are important. And an outstanding example of this is the story of early detection of cerebral palsy. I don't think everybody's going to be able to see the details of this figure, but it's probably very familiar to most of you. This is a figure based on the great work of Iona Novak and her team. And this is a diagnostic algorithm really for early detection of cerebral palsy. So integrating risk factors and standardized neuromotor exams from NICU time all the way through follow-up that allows for early detection. And although this kind of deployment of this early detection mode is generally done in a site-by-site basis, and it certainly can be done that way, this is also a great target for networks of sites to deploy this together. And this is what's shown on the left. Natalie Maitre and colleagues demonstrated the feasibility of larger scale implementation of these guidelines. This was across 5 high-risk infant follow-up programs in the United States. And also, as you see from this figure, there was a demonstration that the age of cerebral palsy diagnosis was substantially decreased with implementation. But of course, the most important thing about early detection is being able to deploy targeted early intervention. And this is an example on the right of such a structured neuromotor intervention. This is from, again, Iona Novak, Catherine Morgan, and others. And this is the GAME, or Goals Activity Motor Enrichment intervention. It is a highly parent integrated, home-based motor intervention. And I think the important thing about this group is that they really asked parents what they thought about this and about the entire process of early intervention. And they acknowledged it was very anxiety-provoking to get that diagnosis, but it was also very anxiety-provoking to not know. And they desired this early diagnosis. This meant to them that help was possible, and for a neuromotor intervention like this, they were really able to be a part of that help. But you know, we know that the benefits of anything that we can offer after discharge can only be ensured if we have equitable access to services. So it may be that you think that, you know, people know eligibility criteria in my area and everybody gets referred to NICU follow-up. That is not necessarily the case. In California, even though very low birth weight is absolutely a definite and an expected referral criteria, only 80% of children who were very low birth weight and discharged from NICUs were getting referred. And very concerningly, there were great disparities about who was getting referred based on race and ethnicity, based on clinical factors, and great variation in sites. So in a quality intervention that, again, brought together NICUs and NICU follow-up teams and included a report that still is deployed and is still very active, which matches discharge from the NICU with whether a child has gotten referred to high-risk infant follow-up, and really expects that as a deliverable. There was a substantial improvement in referral rates from about 83% to 95%. Now it's about 99%. And I will say there was also a great leveling of these disparities we had seen before the intervention. Not complete elimination, so there is really still work to do, but great improvement. And in fact, optimizing that transition from NICU to home is a great target for this kind of intervention. And the Transition Home program, which is at Brown, led by Betty Vore, is a great example of that. And this was actually in partnership with Rhode Island Medicaid. So again, a very strong partnership so that the state and Medicaid really had an investment and skin in the game. This is a comprehensive program, again, that begins early in the NICU. So it's not this disconnect. It's really quite intercalated and includes an interdisciplinary team and many other things. But there have been real improvements that have been shown with this: decrease in rehospitalization rates, decreased in ER visits, and I also point out here decrease in Medicaid spending and healthcare use. Now, that may not be an outcome that we're going to choose or that parents would choose, but this again goes to the partnership and the power of connection, that you can take this back to your partner and say, continue the investment. This is looking great. So in the last 2 slides, I just want to tell you about studies that have not reported outcomes yet, but they are very exciting and great examples. And one is a multi-site RCT of intensive physical therapy among at-risk for neuromotor delay NICU patients. And again, this is a parent-involved and home-based therapy that starts in the NICU and goes through 12 months. And this is in the Chicagoland area. This is Rayanne Desrenier from Lurie, who is one of the investigators. And although the primary outcome is Bailey scores at 12 months in motor score, there are a number of really well-chosen secondary outcomes, I'll say, that include patient quality of life and functional outcomes. The final one is something I'm really excited about, which is in Canada. It is CSENT, and this is an intervention that is focused on parents and supporting them in this transition. And shown here is Paige Church, who's now in Boston, but she is one of the co-investigators. This includes a nurse navigator, it includes coaching, it includes care coordination. Importantly, it includes psychosocial support for the parent. And I think really exciting and important is that the primary outcome here is parenting stress index at 12 months. Not anything else that we might choose, but the parent is the outcome. And the same I will say for secondary outcomes as well. So again, I really want to thank everybody. Thank you to the coordinators for inviting me. I hope this energizes and excites you to get together, go back home, get together with your colleagues, get together with your parents, and think about taking next steps to improve the trajectory of NICU follow-up. Thank you very much.